All right, so let's dive into this. Mark Cuban, the billionaire entrepreneur, NBA team owner, and all-around disruptor, recently posted a blog titled A Few Words on Healthcare. And Sophia, this thing was written in just 90 minutes. 90 minutes. Honestly, I can't even decide which coffee to order in that amount of time.
I know, David, it's impressive, and I've had a chance to really dig into his thoughts on the $5 trillion U.S. healthcare system. He thinks that we could save up to half of that, $2.5 trillion. It's striking how he frames the issue as both deeply complex and yet solvable, with a mix of transparency and reimagining how we deal with administrative waste and profit motives.
Yeah, and $5 trillion. Just saying that number makes me feel broke. But Mark's point is, the system is, well, it's a mess. He mentions things like the overwhelming administrative overhead, opaque pricing, and just flat-out fraud. Can you paint a clearer picture here?
Absolutely. So within those $5 trillion, you've got close to 25 to 30% tied up in administrative complexity. Imagine if a quarter of the system is not about patient care at all, but just handling billing disputes, insurance negotiations, and other red tape.
That's wild. It's like buying groceries but then paying an extra chunk just for someone to argue over the receipt.
Exactly. And this inefficiency is compounded by pricing opacity. Mark uses an example that I think listeners will find relatable. He highlights how the same vial of insulin has wildly different costs. Let's say you buy it through insurance, $40 as a copay, but paying cash at Walmart, just under $25.
Wait, what? That doesn't even make sense.
It reflects how broken the pricing mechanisms are. Insurance companies and providers bundle, upcode, and negotiate rates that are often arbitrary and hidden from the patient. So patients never see the real cost or even understand what they're paying for.
Right? It's like calling a plumber and getting a bill for various water adjusting services. You're just left shrugging while paying hundreds of dollars.
Exactly, David. And Mark's call for transparency, publishing contracts, itemizing costs, is his way of saying, enough is enough. Patients and even large employers need to know what they're really paying for to create a more efficient and fair market.
And it's not just inefficiency. There's a fairness issue too, right? Like, why do prices vary so wildly depending on who you are or what insurance you've got?
Absolutely. That's where fragmentation adds insult to injury. It's not only that you don't know costs up front, it's that two patients might get charged dramatically different rates for the exact same procedure, based solely on what their insurance company has negotiated.
And all of this just leaves ordinary folks stuck between a rock and a hard place, or more like a scandalously priced hospital bill in bankruptcy court.
Exactly. But the good news is, starting this conversation, even from a short blog like Mark's, means people can begin to see where reform is possible. Because clearly the system isn't working for patients or for society as a whole. And speaking of starting points, David, if we zoom out for a minute, the real question isn't just about identifying inefficiencies. It's about rethinking what we want our healthcare system to achieve at its core.
Right? Which, no pressure. Just redefining one of the most complicated systems on Earth.
Exactly. But here's the thing. Complicated systems don't always need complicated solutions. One of the frameworks we keep coming back to, in both research and these conversations, is the idea of a relentless shared vision. We have to ask what optimal health and well-being look like, not just for some of us, but for everyone. And critically,
at the lowest cost possible, right?
Exactly. Because let's face it, if better health equals bankrupting half the population, that's not sustainable.
Okay, but a shared vision, like, practically, are we talking everyone singing Kumbaya at industry town halls? How does that translate into action?
Fair question. It starts at the systems level. And this is where the role of what I call system stewards comes into play. These are leaders who understand how healthcare operates as a complex adaptive system, essentially a living, breathing, evolving network.
Ah, like the Instagram algorithm, but for healthcare.
And just as unpredictable at times. But the point is, these stewards need to recognize that healthcare doesn't operate in silos. Financial policy, community health, insurance structure, it's all interconnected. Effective stewards work to see those connections and leverage them to enact change.
Okay, but who are these mythical stewards? Like, are we talking unicorns and lab coats here?
Not quite. It's people in all corners, policymakers, public health leaders, even clinicians at the community level. But they need the tools and the mindset to think long-term and holistically. It's less about commanding control and more about guiding the system toward resilience and equity.
All right, so step 1, a relentless vision. Step 2, those systems stewards. But you also talked about connecting high leverage points. What's that about?
Great question. Healthcare has what we call leverage points, places where a small shift can lead to big transformations. Think about expanding access to preventative care or redesigning payment systems to focus on outcomes instead of services. If we can identify and align around these high-impact areas, it changes the game.
I mean, sure, but it feels like we're trying to steer an ocean liner with, what, a kayak paddle?
It can feel that way, true, but that's where alignment matters. Even small changes, if coordinated, ripple across the entire system. And when you combine a shared vision with the right stewards and these leverage points, suddenly, big change doesn't feel so impossible.
Okay, I'm sold on the vision, but tying this back to Mark Cuban's approach, how does a blog post fit into all this?
It's simple. Blogs like Mark's and conversations like this one shine a light on areas primed for change. More importantly, they push us to imagine what could be possible if we had that shared vision. I do have to point out one important issue, though. Improving insurance access won't improve health outcomes or equity much. That's for 2 reasons. First, healthcare only contributes to 5 to 20% of our health status that we can change. Second, people without health insurance often still get care, just through less efficient ways, like in ERs. Now, we should still aim to transform the health insurance industry for financial and other reasons, but I wanted to make that clear.
Got it. So we're not just complaining about problems, though there's definitely stuff worth complaining about. We're outlining a future, bit by bit.
Exactly, and it's these conversations that lay the foundation for reimagining models that feel radical, but might just save the system, and all of us, with it.
You know, Sophia, after everything we discussed about shared visions and aligning leverage points, I keep coming back to Mark Cuban's idea. He paints this picture of 1955-style healthcare. Cash pay, direct billing, no middlemen. It's so simple, almost radical. Do you think something like that actually fits into today's complex system?
It's an interesting thought experiment, David. On one hand, his focus on stripping the system down, making it simple and transparent, does appeal to a lot of people. Imagine going to the doctor and knowing exactly what everything costs, right down to the Band-Aid. No decoding insurance jargon, just, here's your bill.
Great, except that bill might make me cry. There's got to be a catch, right?
Well, yes and no. The biggest obstacle today isn't just the prices we pay, it's how convoluted the pricing is. Mark's solution focuses on bills of materials, where every item and service is broken down by cost. Think about a mechanic showing a detailed invoice for car repairs. No hidden fees, no surprises.
Okay, but if I rolled into the ER expecting that, I'd probably leave with a detailed list and no kidneys left.
That's the challenge. For this kind of model to work, transparency needs to be enforced at every level. Hospitals, for example, would need to separate direct care costs, like the doctor's time or medication, from overhead expenses like facility maintenance.
Overhead meaning what? The hospital's espresso machine budget?
Believe it or not, a lot of things fall under overhead. Capital expenditures, think fancy MRI machines, administrative staffing, even the power keeping the place running. Under Mark's plan, those costs wouldn't be lumped in with the care itself. Instead, they'd have their own category.
And let me guess, own category translates to, we'll still pay for it, just differently.
Exactly. But having that data allows for accountability. Why does one hospital charge $50 per stitch while another charges $500? Transparency forces providers to justify those differences or face competition from places with fairer pricing.
All right, but here's another thing Mark suggests. Getting rid of insurance companies entirely. No middlemen, just cash payments for everything. Is this even remotely practical?
It's bold, I'll give him that. In theory, moving to a cash pay system simplifies things dramatically. Clinics already offer big discounts for cash-paying patients, sometimes 20 to 70% less than insured rates, because it avoids all the billing back and forth. but it assumes people can afford or have access to those cash payments up front.
So, what about the millions of Americans who can't just write a check for a hospital stay?
That's where public financing comes in. Mark suggests retooling Medicare and Medicaid to cover those who can't pay directly. It's a kind of hybrid model: cash pay for those who can afford it, and government insurance stepping in for everyone else. But let's not forget, streamlining these programs is no small feat. Consolidating them alone presents huge logistical challenges.
And then there's the politics. I'm picturing every special interest group lining up to fight this tooth and nail.
Exactly. But Mark does point to lessons from single-payer systems abroad. These countries show that simplifying billing, removing profit-centric insurance structures, and focusing on patient outcomes can, in fact, work. The key is adapting those lessons without losing innovation or access.
So, it's 1955 healthcare with a 2025 twist. Sounds great, on paper. But practical implementation? Different story, huh?
A very different story, and one we'll dive deeper into, starting with the role that transparency could play in reshaping the system.
Sophia, as you mentioned, transparency could really reshape healthcare. But here's the thing. This system is huge, messy, and tangled up at every level. Realistically, how do you make something like this truly transparent?
That's a big question, David, but it starts with the basics. Transparency is about leveling the playing field. Right now, patients, employers, even policymakers don't have access to the real numbers. What's the actual cost of a procedure? What's the profit margin? Exposing these details forces everyone in the system to defend their decisions.
So it's like asking Black Friday salespeople to stop hiding the real price tags. Not exactly something retailers, or in this case, hospitals, want to do.
Exactly. Hospitals bundle costs, upcode services, and lump everything into dense bills that no one can decipher. By breaking these practices down into simple, itemized costs, showing, say, how much a standard Band-Aid really costs,
$10?
sometimes more. But by showing the actual price hospitals paid versus how much they charge, you create competition. Suddenly, one hospital charging reasonable margins might attract more patients than another relying on inflated rates.
All right, but here's the catch. How do you get hospitals to play ball? They've got decades worth of profit-guarding habits, right?
That's where advocacy comes in. We need more self-insured employers and groups using their bargaining power to push providers for clarity. Mark Cuban mentions this in his blog about publishing direct contracts. It's a bold move that forces transparency into the market.
Okay, but let's not ignore the obvious resistance. I mean, we're talking big players here. Hospitals, insurance companies, even pharmaceutical giants. They're not exactly going to just roll out the welcome mat for change, right?
Absolutely. Industries built on profit tend to resist disruption. But that's why aligning incentives matters. And this is where your world tech offers some lessons, David.
Oh, tech analogies? Great, now's my time to shine.
Go for it. How do you think insights from tech can apply here?
All right, so take cloud computing. Totally transformed how companies buy and use servers, right? Instead of overpaying for poorly utilized hidden processes, companies started paying for exactly what they used. Why? Because suddenly someone figured out you could streamline costs and still turn a profit. It worked because incentives changed, and transparency backed that up.
And that shift parallels what we need in healthcare. If we align incentives so patients benefit from simpler billing, employers see true costs, and providers get fairly compensated for actual care, it reshapes the system from the ground up.
But how do you spark that change? Self-insured employers might play a part, but is that enough to tackle a whole industry?
Not on their own. Public education campaigns are equally critical here. We need people to demand changes once they grasp how the current lack of transparency impacts them directly. Think movements like fair trade coffee or clean energy. Public demand builds momentum that industries simply can't ignore.
So we're talking grassroots. For healthcare bills. It's a far cry from energy-efficient light bulbs, but hey, stranger things have sparked revolutions.
Exactly. The path ahead isn't easy, but challenging the system means combining pressure from advocacy groups, leveraging innovations like transparent contracts, and empowering everyday people to push for fairness.
Here's hoping we can light that spark. Healthcare 2.0, here we come. So, Sophia, speaking of sparking change, I came across Dr. Graham Walker's LinkedIn post. He broke down how Mark Cuban's ideas for revolutionizing healthcare could lead to actual savings. It's fascinating. There's practical optimism there, but a fair share of challenges too. Let's unpack it.
Right, David. Graham's post is a thoughtful addition to the conversation. He digs into some key areas, like repurposing insurance premiums, malpractice reform, and emphasizing evidence-based care to show where cost savings might come from.
Starting with, what else? Cash pay. Did Graham basically suggest our paychecks would soar if insurance premiums were out the picture?
Pretty much. He points out that the average family premium costs around $25,000 a year. Now imagine if that money was redirected back to households, bigger paychecks for employees, or companies reinvesting in higher wages or other benefits.
Okay, but what if instead of cash, we're forced to set it aside in something tax-advantaged, like an HSA system?
That's actually one possibility Graham mentions. He draws a parallel to Singapore's Medisave system, a way to pool funds and still give people control over routine care spending. Cash pay systems paired with public safeguards can ensure people don't fall through cracks when big costs hit.
All right, but then there's malpractice reform. That feels like another key piece of the puzzle Graham brings up, right?
Exactly. The idea is that reducing costly malpractice lawsuits could lower the incentive for defensive medicine, excessive tests, or procedures done just to avoid legal risks. And if patients know they can access affordable care, even when things go wrong, the urgency to sue might decrease as well.
So are we saying that trust and access go hand in hand with lowering costs?
Exactly, David. And it goes beyond lawsuits. Evidence-based care, another point Graham raises, aims to reduce unnecessary interventions altogether. Research shows that aligning care with proven best practices could save billions, maybe even trillions, in wasted spending.
All right, so we save another trillion. Easy, right? Except fee-for-service medicine still exists. Doesn't that model kind of encourage doing more over doing what's best?
It does pose challenges. Fee-for-service can incentivize volume over value. But as Graham notes, fixing structural incentives is complex. We'd need payment systems that reward positive outcomes instead, focusing on preventative care and keeping people healthy rather than just treating illnesses after they occur.
Okay, but fixing all these systems doesn't magically make more doctors appear, right? Graham touches on that too, the shortage issue.
True, but streamlining bureaucracy and reducing costs could bring some healthcare workers back into the fold, those who've left due to administrative burnout. And a healthier population overall could free up more appointment slots. It's not the whole answer, but it's part of it.
So less stress for docs, fewer lawsuits, actual savings on care. Is healthcare reform finally sounding plausible?
Let's not celebrate just yet. But what Dr. Walker's post reminds us, David, is that pairing bold ideas with actionable steps, however imperfect, is still a step in the right direction. Whether it's transparency, cash pay, or evidence-based care, every reform effort chips away at the barriers that make healthcare so inaccessible today.
All right, Sophia. After everything we just went over, I've got to admit, healthcare economics feels like solving a 3D puzzle blindfolded. I mean, I can barely keep track of my grocery list sometimes, let alone tackle those big, messy systems like a pro.
Exactly, David. We're not experts, and this whole conversation has been a learning process for both of us. Honestly, I think that's part of the value of what we're doing. We're exploring, engaging, and making sense of these huge, overwhelming issues together.
And hopefully, not making too much of a mess along the way. Honestly, it's kind of daunting. Trying to tackle something as gigantic as healthcare and still realizing, we might not even be presenting Mark Cuban's ideas or Dr. Walker's insights perfectly.
Right, and that's okay. The point isn't that we have to get it all 100% right. It's that we're having the conversation, shining a light, and peeling back the layers of complexity where we can. It's about staying relentlessly focused on what really matters: health, equity, and efficiency.
Which all kind of sounds like the ultimate balancing act. But hey, simple, clear conversations like these are part of making these big, scary topics less abstract.
Exactly, David. And that's something everyone, whether you're a policymaker, a doctor, or just an interested listener, can contribute to. It's being curious, being bold, and being ready to challenge the status quo, even if you don't have all the answers up front.
So basically, folks, we're learning by doing here. And on the bright side, it's way cheaper than med school.
Haha, very true. And on that note, let's keep the conversation going wherever it takes us next. It's been great talking with you, David, and exploring this with everyone listening.
Agreed, Sophia. Well, that's all for today, folks. Take care, stay curious, and we'll see you next time on It's Time.